to be here. I'm an internal medicine resident at Mayo Clinic Rochester in Minnesota. I'm currently interested in rheumatology. I'm in my second year of internal medicine, so I'll be applying shortly for rheumatology fellowship. And that's essentially how I got involved in the study through mentors such as Dr. Koster, who helps with histiocytosis to a degree. He invited me to work on this case, and that's how I was involved in this.
Yeah, thank you again for this opportunity. One of the ways that I've been involved with histiocytosis, which when you think about those conditions, you're not automatically thinking, oh, I should go see a rheumatologist or a rheumatologist will be part of my treatment team, is really from kind of challenging cases that have rheumatologic overlap. So some of the patients who end up having histiocytic diseases will end up having symptoms that may mimic some of our rheumatic conditions and may be mislabeled or misdiagnosed. I have the honor of being part of our histiocytosis working group that started at Mayo approximately 13 or so years ago. Started with Dr. Gaurav Goyal, who's at University of Alabama, and Dr. Ron Go, who's still here in hematology, and they still lead that group. And it's expanded to many different specialties, including rheumatology, but a very diverse group of people who try to come together to assist diagnosis and also management of patients with histiocytic diseases. So my training, I'm a clinical rheumatologist. My area of focus is vasculitis, which is kind of pertinent to this case specifically, which I'll be happy to kind of share in more detail. Yeah, certainly. So again, my area of focus is vasculitis, and one of the areas of special interest is large vessel vasculitis. So the large vessels are predominantly the aorta and kind of the immediate branches off the aorta. And so conditions that are typically thought of in the rheumatologic community involving those territories are things like giant cell arteritis, or the younger version, something called Takayasu arteritis. And also conditions that are kind of more newly understood, things like IgG4 related disease, which some of the community and the histiocytosis group may be aware of because of questions of that having many overlap in the different organ systems that histiocytosis conditions can cause. And so this particular case, the reason why we wanted to highlight it is a couple. One is to highlight some of the particular findings that are important to recognize very quickly as being the likelihood of a histiocytic disorder, because often these cases, if not identified appropriately, will be misclassified or misdiagnosed and then ultimately mistreated, as this case was for several years. So this case was actually highlighting a gentleman that came to see me in clinic, and the way that it came to me was by a phone call of a provider who had been following this patient for a few years, had been treating with prednisone without much improvement. And so they wanted to refer the case to the vasculitis clinic that I work in, because the patient had significant abnormalities with thickening of the aorta, and it kind of extended down into the abdomen and had been listed or labeled as a concern of something called retroperitoneal fibrosis, which is also something that can be seen in Erdheim-Chester disease, and we'll talk about. But that was really how that patient came to us. But the important thing is that when you look at the scans of these types of patients, if they've had CT scans, there's some key findings that have been known to the histio community that are pretty characteristic for patients with Erdheim-Chester disease. And that's something called a coated aorta. And what we mean by that is kind of thickening around the entire circumference of the aorta. And it often involves both the chest, thoracic aorta, and the abdominal aorta, and continues throughout that entire area. And it's different than some of the other diseases we treat because it can have very significant thickening, often more than what we would anticipate from some of our other rheumatic conditions. The other thing is kind of this area of thickening around the kidneys. Something called hairy kidneys is kind of the way that people describe them. And so when someone is seeing this coated aorta, this thickening of the aorta, and this kind of projection of soft tissue thickening around the kidneys, essentially in our group at Mayo and the histiocytosis working group, is we presume it's a histiocytic disorder until we can prove that it's something else. The issue is that often radiologists or other people who are not seeing these kind of rare conditions at a higher volume will label it as something else, and then the person who sees the scan report will treat it as something else. And so this gentleman had been having symptoms for several years and was continuing to decline. So part of what we really wanted to highlight is those specific features of things in which inflammation of the aorta is something that can happen in the context of histiocytic conditions, particularly Erdheim-Chester disease, and trying to make sure that you push to evaluate and confirm that condition. That's one of the main things that we wanted to highlight. The other thing is the response to treatment. And so in these contexts, it's really important that if we're identifying a patient with Erdheim-Chester disease, prednisone doesn't work well. And so while sometimes people have elevated inflammatory markers and people will try steroids, it's not a definitive therapy. There are newer therapies that are very targeted against kind of these mutations that can be seen in the tissue. And that's one of the needs of what is required to be done when people are evaluating with biopsy is there are some stains that can be done to look for something called BRAF V600E. That's kind of a thing that's kind of familiar within the histio community as far as options of therapy for treatments that target it. But if that's not seen on a stain, there's additional testing that can be done that looks more at the genetic level, the mutations in the tissue. And that was key in this particular case because it identified a specific type of mutation called a MAP kinase mutation, for which Cobimetinib, a MEK inhibitor, is approved for. So we were able to partner with hematology after getting adequate tissue, confirming the case to be Erdheim-Chester disease, and in our institution, hematology ends up managing these patients. And so really that's one of the things that we wanted to highlight is both the diagnostic odyssey that can take place and trying to find ways to really educate both patients and providers that these are key findings to consider for histiocytosis conditions. I'll let Dr. Ahmed speak a little bit to kind of what are some of the important elements about arterial disease in Erdheim-Chester and kind of the important findings in regards to the lack of information and also the response to therapy that was highlighted in this case.
Thank you for that, Dr. Koster. Yeah, so as the audience may or may not know, as we've summarized, Erdheim-Chester is one of the histiocytic disorders where the myeloid cells or the cells that are histiocytes have a mutation that recently has been described to be kind of cancerous or neoplastic, which is why now often hematologists will see them rather than rheumatologists. And these cells create inflammatory cytokines that can cause various symptoms. The cells will go to certain organs and create the cytokines, leading to inflammation and often end organ damage. Among the organs is the large vessels, which is why a rheumatologist who studies vasculitis may see a patient like this. But the different thing about Erdheim-Chester with large vessel involvement is some of the characteristics you see, as Dr. Koster alluded to, very coated, circumferentially thickened aorta, kind of involving a significant portion of the aorta from the chest to the belly. If you compare it to some other diseases that involve the large vessel, such as GCA, often it's more asymptomatic, although it can lead to complications. So, for example, GCA can have ectasia slash dilation or even aneurysms of the aorta, or conversely can have narrowing slash stenosis or complete occlusion or blockage that can lead to symptoms. Erdheim-Chester, when it has large vessel involvement, can technically lead to complications such as those, or even other times narrowing of the arteries that lead to the kidneys, leading to high blood pressure that can, improve with stenting. But these are less common. So because, although the thickening can be very impressive on imaging, because it's often asymptomatic, it can be overlooked both from the clinician and patient and also in the studies that we have. Again, because Erdheim-Chester and histiocytoses in general are so rare, they're not as well studied as other common conditions. And on top of that, with arterial involvement being often asymptomatic, we don't have many studies. But when I was reading about and looking into this case, there was a study that looked a little more at arterial involvement. It was a single center observational study. It did look at about 64 patients with Erdheim-Chester, specifically with vascular involvement. And the interesting thing in this study is it did show vascular involvement, again, is very frequent, often about 50% of patients. What's interesting is that the response to treatment is not well studied and is often not very responsive. So if you look at the study, partial response, the highest number that it even quotes is about 11% in the lower part of the abdominal aorta. And a complete response was even lower at 9% at the highest in a slightly higher part of the abdominal aorta. So for our study, the interesting thing is that on the PET scan, which is one of the images that looks at inflammation lighting up on the scan, there was a complete response in the sense that the initial PET scan and the second PET scan showed a complete change in the inflammation. Now, theoretically, that has been shown in other studies that the PET scan will show response, but it's not too common. And many times at Erdheim-Chester, even though there is vessel thickening or inflammation, the PET scan won't show much. In that study I mentioned earlier, only about 30% of the patients who had arterial thickening actually had findings on the PET scan of it lighting up. The next thing that's interesting in that study is they didn't have a chance in those cases to do the mutational testing Dr. Koster alluded to in many of the patients. So I believe only 22% of the patients had that mutational testing. Of those, 12 were the BRAF and mutated, and the other 10 were the non-BRAF. So another pathway is the MAP kinase pathway, and there are other mutations in that. So of the patients who had the BRAF mutation, they were treated with BRAF inhibitors. And some of them had response and some of them didn't, as I mentioned. But none of the patients in that study were treated with the MEK inhibitor like Cobimetinib. So that's the other reason why our case was interesting, in that we showed Cobimetinib led to complete response of the PET findings. Now, the last thing I'll kind of speak of for this question is the way we image and follow, arterial findings. You can use many imaging findings. So in that study, again, there was PET scans, there was CT scans, there was MRIs, there was ultrasound, and even other various imaging modalities like digital subtraction angiography. But what's difficult is when you're doing an observational study is, kind of standardization. The patient may have gotten a PET scan at one point and then they got a CT at another point. So how do you kind of see, is the change over the imaging actually significant, because you're not comparing apples to apples? So that makes it difficult to know response. And CT particularly, although it is good for looking at stenosis or dilation, CT hasn't been studied as well. And it hasn't really shown much response when it has been studied. So in our case, if you look at the initial CT, the maximal thickness was about 10 millimeters or 1 centimeter of the aortic wall initially. And when we got the repeat CT at the follow-up after treatment, there was about a 50 to 70% reduction in the thickening, which is very significant because, in Erdheim-Chester, you can have more acute inflammation of the thickening of the wall, which may respond to therapy, but other patients may have scarring or fibrosis over time, which may not be reversible. And that's sometimes maybe why we don't see response to treatment. But in this case, there was such a big response, and perhaps that's because maybe this patient had more of the inflammatory rather than scarring or fibrotic manifestations.
I think one of the main things is trying to understand that there are some parts of the process for histiocytic disorders that respond dramatically to treatment and others that don't as dramatically. And as Dr. Ahmed ended up mentioning, some of those are because initially they'd be more fibrotic, right? That's where the dual benefit of imaging modalities are important. Now, traditionally speaking, PET scans, if a hematologist is following them, is kind of what is used. The question is, how are things in regards to arterial follow-up? Is there improvement in the narrowing? Is there decrease in the thickening? These are things that are not well studied and not done in a very systematic way. So one of the benefits that I think that'll be important is really identifying kind of more of what we call prospective, meaning kind of determining things from time point now to forward, how things are, with a little bit more of a standardized approach to patients with large vessel involvement, to say if we identify it, we need to find a way that we can monitor it to really determine how things are improving and to determine if we're able to identify an actual benefit in regards to these types of therapies that are more targeted compared to non-targeted therapies. So that's really, I think, one of the next steps of areas that we're looking into. I think the other element is to make sure that patients, when they're being evaluated, that there is the attempt and intent to do next generation sequencing on the tissue to determine, are there certain types of mutations that tend to respond better to these therapies than other, to be able to give kind of more of a prognosis in advance to say, okay, well, here's what we're dealing with. These are the types of locations we have involvement. This is what we see on the scans. This is the type of mutation you have. This is what we can expect for outcome. Really, some of these things are a tailored approach to the patient. And it's really, while there's similarities across Erdheim-Chester in general, each kind of approach to the patient has some nuance, and it's trying to identify more of that patient level nuance.
The only thing I would add, essentially, obviously, it's difficult with the rare disease like histiocytosis to do, very large or structured studies at times, especially, the ideal would be a randomized controlled trial, but it probably wouldn't be that feasible. But again, if we have prospective studies where things are as standardized as possible, that will help us best assess both the response to various therapies and based on which imaging modalities are we seeing that response. And it would be important, as our study kind of alluded to, although it's a single case, is to try to use both types of targeted therapies. So for BRAF inhibitors or for the other mutations, one of the most common being MEK inhibitors, and the more traditional anti-inflammatories or chemotherapeutics when they're indicated, as they were historically used very frequently, but now they're being used less and less, given how effective the targeted therapies are.
And one thing that I'll just add to that as well is that some of the data that patients look at is old. So some of the things like cardiovascular involvement, large vessel involvement, when you notice that someone has that, if you look at potential outcomes or risk of death or risk of progression, cardiovascular involvement or aortic involvement has historically been something that has been associated with an increased risk of disease, increased risk of death. And a lot of that is older data from the 90s, early 2000s, before we really understood very well these point mutations that could be targeted with therapy. And we're seeing a shift that when patients are recognized with these disease, recognized early and treated early, that we're able to see better outcomes. And so I think it's really trying to identify what those outcomes are in the current landscape so that we can provide updated information and more hope to patients so that they're able to identify this is really what I can expect, as opposed to things that are 10, 20 plus years old that may not be accurate for them to understand for their disease. But I would just say thank you for providing us a platform to highlight these things. I think one of the main elements about histiocytic diseases is that while they're rare, sometimes difficult to treat. The more education there is, both from kind of patients, from providers, from resources like this, it provides a broader understanding to recognize early, to diagnose appropriately, and to treat correctly. And I think that will allow for better outcomes for all patients going forward.